Here are the details that every American needs to know about this plan.
Medicare will become law on July 1st, 1966.
I want America to have the finest health care in the world.
This healthcare system of ours is badly broken, and it is time to fix it.
Well, we spend $2.7 trillion every year on healthcare.
Our healthcare is too uncertain and too expensive, too bureaucratic and too wasteful.
This legislation will not fix everything that ails our healthcare system, but it moves us decisively in the right direction.
And we will always protect your Medicare, and we will always protect your Social Security.
This is what change looks like. This is what change looks like.
Awesome. Well, Jason, thanks for coming on the show. How are you?
I'm great. It's glad to be
Awesome.
on it. Thanks for having me.
Yeah, absolutely. Thanks so much for being here. And, Jason, I wanted to give you the floor real quick right off the bat and let our audience know what you guys are doing over at Helgerson Solutions Group and just how you guys are truly, for me, I've read a lot of your stuff and it seems to me you are really forward thinking, really progressive in the manner of the future of healthcare. And I would love for you to tell our audience what you guys are doing.
Sure. So just a little bit of background on us. So I founded Helgerson Solutions Group a little over 2 years ago when I left government after 20 years in government, most of that in Medicaid. I was a Medicaid director in New York State for 7.5 years. Before that in Wisconsin for 4 years. So I left government. I was the longest standing Medicaid director in the country, which I always say I'm not sure what that says about me, but had many years of government healthcare experience and in my most recent experience, driving the state of New York's movements into value-based care and really trying to move away from fee-for-service reimbursement into these value-based arrangements, focusing on Medicaid, but obviously with the hopes that it would transcend Medicaid and go across other product lines. So when I came out of government and started this firm, I was very, very interested in wanting to do work in this space and working with organizations, large and small, for-profit, nonprofit, that are committed to the move to value in health and social care. And also I think, and so really we're a firm that's focused on that. And that's the kind of organizations we work are ones who share that commitment, that value, that interest. And we like to work, we see the journey to value as a journey. And we like working with organizations who are at some point on that journey and help them sort of get to the next destination point. I think what also makes us unique is that we're global. We've got employees in England and we have employee in Brazil, and we see the move to value is not a unique to U.S. Conversation. In fact, there's some very serious conversations happening around the world about what does value-based care mean. And I think that while we pay for healthcare differently in different countries and in different ways, there's a sort of common understanding of the need to, make more of the payment that's made in the system accountable based on outcomes and really measuring outcomes in more definitive ways. There's also an interest in trying to make it more integrated, getting organizations to work together in common cause to improve health and social outcomes, and sort of a growing understanding, acceptance, and belief that if you don't address social needs, what we call it here in the U.S., social determinants of health, you're not going to be successful in controlling total cost of care. So when we started, I was very much interested in that space, in the global space, the move to value space, and that's in essence the firm we have today. And so we have a variety of clients ranging on the small end, startups, new into this space, selling services or looking to contract for services, to academic medical centers, payers, even governments on the large end, and lots of organizations in between.
Wow. Yeah. And then it's cool. Like that's one thing that drew me to you right away was the global reach that you guys have. Now, let me ask you, what is like a major learning that you guys have gotten from working globally and not really, bordering yourself off to the United States?
Yeah, no, great question. And I think it's that healthcare suffers from this more than other aspects of our economy, other aspects of our lives, in the sense that learnings don't jump from one country, one part of the world to another as much as they do in other areas. I think if anything, COVID-19 has shown us is that we all live in one world, and what happens in Wuhan, China, matters in Philadelphia, Pennsylvania, in the United States, and then we shouldn't just be thinking globally in health and healthcare during a pandemic. We should be thinking about it and trying to learn from each other in just how we provide care even outside of these sort of crisis situations. And we've seen, for instance, when I was in my old job as New York State Medicaid director, we formed a strategic partnership with National Health Service in England because we were both proceeding forward with move to value. A move to integrated care was very similar, eerily similar in terms of the structures that we were looking to put in place. And what we found when we got into doing work there and really, getting into the detail of what they're doing, we saw some amazingly interesting practices that are of complete applicability here, and vice versa. And we had many, and we still today host organizations, groups of people from the UK to come to the US. But that's just one example. I think there's a lot more that's going on around the world that is going to be things that we can learn from. And whether it's big structural, like things like accountable care organizations, they're talking about creating those in Saudi Arabia today, actually, of all places, to actual new care models, delivery, things that are innovative practices that have worked, that improved outcomes and lower costs, things that could be done here or that have been done here that are replicated elsewhere. But then also practices that we could absolutely adopt here in the U.S. that have been successful in other parts of the world.
Very cool. Very cool. Now, for me, living in sort of this, Medicare Advantage, large at-risk physician group kind of bubble, and our clientele are those groups in the United States. So I haven't really gotten outside of the United States bubble. As a world, as a global healthcare community, really, where do you see us? Where do we stand today moving into that value-based care? Because we've really been talking about this since, really before even the Accountable Care Act was signed. We've been talking about value, but where do we stand globally, maybe even as a country, on our journey to value-based care?
Sure. So I'll take the U.S. first, and then I can then go into the globe itself. And I'd say is that when we get to the discussion on the globe, is that countries measure value in different ways. Although I think that the value definitions are beginning to sort of come into. There's more commonality now, even than when I really started thinking about what was going on and talking to people in other countries, say 10, 15 years ago. I think there's a lot more commonality now than there was, but there's still different definitions of value. But when I think about the US, I think we're still very much a work in progress in the journey to value. I think that the good news I take is that there's very few people left who really defend the fee-for-service system. There's disagreement in terms of what should replace it, but very few people are willing to stand up and say, this is great. American healthcare is great. Let's just keep it the way it is from now until the end of time. In some ways, it's like COVID-19 is further done that, because organizations, healthcare providers, whether it was primary care providers or hospitals, organizations, long-term care providers, anyone who's in the fee-for-service world has almost certainly in American healthcare seen revenues go down, in some cases to dangerously so from a financial standpoint, because of stay-at-home orders and cancellation of non-essential procedures and things like that, which I think is lighting a bit more of a fire under these providers to want to get into these risk arrangements. But I think that, so what I'd say is while we're still a work in progress, I think we're getting closer and closer to that tipping point. The tipping point at which both the payers and the providers are like, enough already, let's finally flip the switch and sort of go all in on that. And I think that in private conversations I've had, particularly like in the hospital sector over, say, the last 5 years, there's general acknowledgement that the system is going to change, but there has been some hope in some of these organizations that they could squeeze out that fee-for-service, margin for a bit longer before actually flipping the switch. I think in some cases, these organizations are being very short-sighted and playing a very dangerous financial game because it's not as easy. And any organization who's made the journey from fee for service to value knows that journey is challenging, and it takes a while. You can't just culturally flip the switch on an organization that was built to maximize fee for service revenues and all of a sudden wake up one day and you're managing population health. That transition takes time. And I think my fear for them is that some of these organizations may have wasted too much time. And the journey to value for them is going to be very, very bumpy. And that is a fear that I have. But I think all in, I think by the middle of this decade, I'm projecting that 70 to 80% of all reimbursement in the United States across all payers is going to be in some kind of a value-based arrangement. Not as far into value as I might like, but we'll be somewhere there. Because if you look at like the Medicare projections and more states going that way, and then commercial payers, obviously. But that's where I think. But still a lot of work to be done. Globally, I think that when we think about value-based care, it's interesting. In these other countries, they think about it less from a payment standpoint and more from are we really focused on outcomes standpoint? And sometimes the outcomes that they want to focus on are things that are associated with cost, but sometimes they're not. And I think that where we are at globally is we don't have a common set of metrics, despite the fact that to a great extent, medicine, healthcare is, especially in the developed world, is provided in very much the same fashion. We're all human beings, right? A diabetic is a diabetic is a diabetic, whether they live in Singapore or Kuala Lumpur or Philadelphia or London, Paris, you name the city, all diabetic. I mean, yes, things that can challenge and the related to their illness and how you treat it effectively. And yes, there are some variations. We always love to highlight the variations in how care is provided in the U.S. Yeah. Yes, but those variations, when you take a step back, really are relatively modest. And so I think at the end of the day, one of the things that would be good would be if we could move the whole planet towards a more effective way of measuring our health systems and really evaluating ourselves on that using a common set of metrics. I think would be a positive step forward. So I do think as a whole, we got a longer way to go than we do potentially as a country.
Yeah, and it's funny you talk about the metrics globally, right? We don't have a common set of metrics between payers here in the United States when it comes to quality, right? That everyone thinks that their 11 to 13 metrics are the end all be all, right? So I think that's even, when you get down to even the commercial level and things like that, that's even, something to be moving towards.
I agree with you, but I think at least, we have HEDIS metrics, right?
Yes,
which have been commonly utilized by health plans for long periods of time. Lots of comparability options there. Yep. The star ratings obviously are standard approach across Medicare Advantage. But you are right. I mean, so, we don't have it as good. And I would argue that a lot of those metrics are more process. They're really not the outcomes. And we need to get better measures. But in England, for instance, where they're creating integrated care systems, which are very much like accountable care organizations in a lot of ways, they don't have a standard national measure set other than very much process type things like how long it takes someone when they arrive at the emergency room, does it take for them to be treated? Like those kinds of process measures, which do mean a lot in their system and in their country. They don't have that kind of robust system, even though they have actually consolidated within that one system, National Health Service, a lot of data, much more consolidated than we do, and could actually really be looking at some interesting outcomes, but for a variety of reasons haven't done that to date. So that I think, as I say, I think we actually on the measure side are a little bit more advanced.
Cool. Cool. Well, that's definitely good to hear. And I think you mentioned something earlier about the challenge from going from fee for service to a value-based organization. And do you think that challenge is really what's holding people back from, diving all in instead of like dipping a toe in?
I think it's partly that. I think that there's if it's broke, if it ain't broke, don't fix it.
Yeah.
So I think it, at least for a while, a bunch of organizations have felt that their margins are positive, and that they've been fearful of giving up that in exchange for some, new system, even if they know in their heart of hearts that new system is where the whole world, and the country at least, is going. And so I think that they've been hesitant to want to do that. And I think though that, and this is where I'm actually bullish on some of the organizations that you talk about in the MA world. I'm very bullish on some of these startups, the Oak Street Health, the Ioras, Caremore's. I'm really interested in these sort of innovators who are built entirely around value-based. I mean, that's what they are. That's who they are. Yeah. And them coming in and really challenging the status quo. And I think, to be honest too, is that a lot of the major healthcare players in the United States are nonprofits, right? Who, are not yes, they compete, but they're not, but they're so large that they're not like the most nimble entrepreneurial type organizations. And they haven't really had that much of a challenge brought to them. And so I'm actually hopeful that some of these organizations are going to begin to get to a level and a scale that's going to begin to give them the opportunity in certain markets to really challenge, and that will help sort of push these, I call legacy healthcare system providers, into moving more quickly and really becoming more entrepreneurial as a result of facing, serious competition in some cases for the first time.
Yeah, absolutely. And I think that is definitely important as you kind of look into the future. That entrepreneurial startup mentality is pushing the envelope, innovation, right? And there's that statement, necessity is the mother of innovation, right? Or invention, right?
Yep.
And I think we are at that state of necessity. And especially you hear of these, these doctors' offices closing, these hospitals closing their doors. I think we are at that stage where it's cool to look at those, those newer age organizations that are coming to the forefront. From your experience, seeing them and being where you are really at the forefront of this value-based, what are they doing differently coming to market? Obviously being value first, but are they doing anything differently from like a best practices point of view that you've seen?
Yeah. So I think it's a great question. And I think what they understand is that the user experience is exceptionally important and a tremendous opportunity. Generally speaking, for most people in the United States and more generally, the user experience in healthcare is terrible, right? Mm-hmm. We expect people to wait really long periods of time to get services. Oftentimes people are not treated well as they work their way through the complexity of health insurance and all these different providers and such. And thankfully, there's a lot of really good, smart, empathetic people in the system still to this day, but there's a lot of bureaucracy and issue around that. And the length of time. I mean, I always joke that is that if Amazon pursued a business model similar to a typical, say, primary care practice, at 5:00 on Friday, they would change the message on their voicemail system to say, if you were calling for an appointment, that, oh, by the way, if you wanted to see somebody now, afraid our office is closed, call 911 if it's really urgent. If not, call us back on Monday morning and we'll try to get you in at some point. Right? It'd be like Amazon shutting its website down at 4:59 and telling, its potential customer, either wait for us until early next week or go to our competitor and pay 3 times as much for that same sweater. I mean, but that's typical, all right? That message is on almost every primary care office's answering phone every single day. And this idea of waiting around for care and people's experience, and people have done some innovative things to try to make that better, but most of the time that user experience is bad. So a lot of these organizations that we're talking about here, the innovators, have made that user experience and improving it and streamlining it like one of their absolute key priorities, to try to get people into care as quickly as possible. This is where I think the virtual care, which we're seeing so much of with telehealth in the COVID-19, is coming to the fore. A lot of the regulations that made some of that a little more difficult are getting just blown away by all of this. So I think that this is going to become a more and more of a part where people are going to vote with their feet and go to providers who provide a better user experience. And I think that's what some of these innovative organizations have done, is they've figured that out. They figured out how to change the model to make the services that people need the most, as accessible as possible. Because the thing they don't want, right, is, an Oak Street in, let's say, Philadelphia doesn't want their patient that for whom they're at risk for to not be able to get services from them and instead get something much more expensive from the hospital. That's not as common of a sense of urgency around that as you have as is felt, elsewhere in the healthcare system.
Yeah. And it's cool. I've been telling people this story since Saturday, but I went to the doctor Saturday morning at 4:30 in the morning. And everyone's like, you didn't go to the doctor. I'm like, yeah, I did. I went to Teladoc. And like, and it's one of those things that's cool to me. And like, do you see those policies sticking? Like, you don't see those things going away, right?
I don't think so. I think the only issue that you're going to see is there's generally most payers are having rate parity. So they're paying the same amount today for a televisit as they do for a physical bricks and mortar visit. I don't think that parity is going to continue beyond the pandemic period. And I don't think frankly it should. I just think there's economies of scale that you can get in telehealth, and there's less cost, and it should be cheaper. And I think that the people who are providing virtual care know that and such. But I am seeing in some of the work that we do also is advise venture capital, private equity firms as they're making their investment decisions. And so particularly on the VC side, we're seeing lots of new innovative companies, just like the ones I'd already mentioned, that are coming to the fore that are going to be really interesting, leveraging technology to the hilt. And I think that, but it's not just technology to save money. It's technology to improve the user experience, to make healthcare available at 4:30 in the morning, because that's when you need it, right? And that's the fundamental shift, because that I think is going to be so key for these organizations, that they get that access and convenience are really critical. And that's a way to differentiate themselves from the physician group down the street.
Yeah. And I love the access and convenience, right? Like convenience is king, right? When we look at business models in the, private sector, like let's say a gym, people don't go to gyms that are outside of a 5-mile radius of their house because, well, I don't want to drive that far to go do something I'm not super pumped about doing in the first place. And so I think it is that, convenience being king and the tech being forward and actually doing business in the 21st century, right?
Yeah.
So
but the only thing I would add, I agree with you 100%, but one thing I would add is that the user experience is more than just speed. It's also what happens, what is the experience like? And that is the thing about healthcare that is different than buying a sweater on Amazon, right? It's that I'm often, when I'm going for a service, like I could be scared. I could be feeling terrible. I could have tremendous sense of anxiety about what it is that could be wrong with me. So when I access that service, whether it's in person or virtual, that interface has got to be empathetic, right? Compassionate. It's got to be whoever it is that I'm communicating with, whether it's through a computer, on my phone, or I'm sitting with them. That piece. That's why it's like Iora is a good example. I mean, I love the fact that when you go to their website, the first words you see on there are empathy, and they take this mission of theirs as part. And I think that they build that into their organizational culture. And I think it's got to be convenient, but it's also got to put empathy. You really want that person that you're interfacing to be listening, right? To take, and that's another piece of this that's been lost by fee for service. And I think it's one of the more corrosive aspects of this, which is like, think primary care, for instance. Average length of a primary care visit, in terms of the visit, meaning the face-to-face interaction with the doctor, the nurse practitioner, whoever it is that's the highest level person that you're interfacing with, you're spending less than 5 minutes with that person.
Yeah.
And it's become necessity because of fee for service. Like, I got to book these appointments, and it's an assembly line. And somehow, we lost the humanity in healthcare. We turned it into, General Motors. And I think that one of the things these startups, this is why I'm so excited about them, is that they're trying to bring that humanity back into the business. And that is what's important. And I think that that's going to also differentiate them, in addition to speed and access.
Yeah. And I love that. It is about bringing that humanity back into the care, the empathy, and actually, being able to sit with someone and go into, like you've talked about, social determinants of health, right? And I'd love to hear your opinions on the moving forward in that, because when we talk about humanity, that is humanity. Are the people that we're caring for, are they food insecure? Do they feel safe at home? Do they have transportation? I'd love to get your opinion on how social determinants of health are bringing humanity back to medicine and pushing us forward in value-based care.
Yeah, I mean, I think social determinants of health, and I know there's actually quite a bit of frustration out there around the country, and we've worked with a number of organizations who come out of the social care world, and haven't felt like they've been able to connect with and get through into contract with payers or these at-risk healthcare providers. And it's been very hard work, and they feel underappreciated, disrespected, and feel like there's tremendous missed opportunity. And I think that there's definite truth in that. I think the good news is everyone agrees SDOH is an issue, and we need to address it.
Yeah.
What we haven't yet gotten to is a set of strategies for how to address that within the healthcare system, like really defining, these are things that the healthcare providers, whether that's plans or actual providers themselves, these are things they can do to address the SDOH needs of their patients. And here's how they can contract or work with organizations to do that. We have things like Unite Us, right? These closed loop referral systems that have become quite the rage, and lots of organizations are contracting with them. But ultimately, Unite Us provides you a tool to support a network of organizations that can help address housing, food insecurity, whatever. But it doesn't necessarily mean that the organization that provides that service does it well, has capacity. It doesn't always solve this SDOH problem. So I think we still have a ways to go as a country in terms of trying to figure out the models, the relationships, the contractual engagements that will really get us to that point where we begin to systematically address. But this is also an area where I am, I'm all for the work with nonprofits. I think there's some interesting opportunities for some entrepreneurs in this space. I would love to see some companies begin to come to the fore that are specifically built around addressing these SDOH needs of individuals. I would love to see some competition around how to, increase food security amongst really low-income, vulnerable people. I think there's some interesting stuff there that could be done. And also, I'm also interested in, the models, the companies we talked about. They built it in, right? They just say, this is part of what we do. This is how we're going to do it. We're going to do it ourselves. Or small numbers of outside contracts. I'm for whatever way works to address them. I'm for, and I think we should be constantly experimenting and looking for new types of relationships. But I think that's the one piece that is that there's a lot of talk about SDOH, but there isn't as much out there actually being done yet. But I'm very hopeful for the near future on that.
Yeah. And I love that action step. And as we kind of conclude today, I'd love to actually hear, if I'm a physician executive listening to this podcast and I'm going, man, maybe I was hurt by COVID, or maybe I'm looking to get into some risk-bearing contracts. What would you say is like step one how do you get into this and actually make sure you're navigating it properly, but doing the right things moving forward?
Sure, sure. So if you're a small group practice, right? First and foremost, you need to think about who you serve, right? And
Mm-hmm.
what's your patient mix. What are the most important payers to you? If your biggest, most important payer is Medicare, the first thing I think you do is you look at the various APM models that exist and think about what you could potentially do there. If your biggest payer is Medicaid, then I think you need to sort of look and see, well, what's the state's Medicaid policy relative to value-based arrangements? Are there any programs and such that I participate in? If it's commercial, then I think the question is your commercial market dominated by certain bigger insurers? Some markets there's more payers, and other markets it's a more consolidated. But if it's consolidated one, I mean, look at what programs potentially they might have to offer. Most of the big insurers now have some kind of program, standardized program, that particularly for primary care physicians can participate in, because they ultimately like to get providers into risk arrangements. And so they've created sort of standard programs that you could potentially enroll in. But the other option, and I think this is what you're beginning to see, is providers are aggregating. And I think some of this was, informing IPAs and to a little bit lesser extent ACOs. But I think IPAs are an interesting opportunity, because I actually think that the future isn't the hospital. The hospital has been the dominant player in American healthcare for, at least back to, before, or maybe back to World War II. It was, and if you think about the history of the hospital was in essence operated as a charitable service, only meant for the sickest of the sick. And if you only went there when it was absolutely essential. In fact, wealthy people basically had her services brought to them to the greatest extent possible. Fast forward to today, and these things are these monolithic, they're often the largest employer in a lot of communities. But I think that their days as the dominant are coming to an end. And I actually think that the future is going to be people who provide those sort of primary care type services. And I don't necessarily is going to be one where you have we're not going to go to a world where everybody just has a signed PCP and it's that simple. But I think there's going to be organizations that are really responsible, first and foremost, for your care and helping you access care. And that's going to take a variety of forms. But I think a lot of those organizations are going to be physician-led. And I think it's a great opportunity for primary care and other types of physicians to really take on more of a leadership role, to get upstream in the reimbursements, and to ultimately have greater control over their professional lives. And instead of being sort of dictated to by insurance companies and large hospitals who have had so much of the control, the interesting, I think, exciting thing about value-based payment is that it's ultimately who's controlling attribution. You need to attribute a person to a provider for there to be a value-based arrangement in most cases. And usually the most powerful, most commonly used attribution mechanism is primary care. Who has the strongest sort of primary care type arrangement with a particular patient. And I think at the end of the day, those are doctors, right? Or nurse practitioners. Those are clinicians. And if they can decide how they want to organize themselves or where they want to work. And I think that it'll be very interesting to see is will they sort of harness the potential power of value-based payments and use this as an opportunity to ascend up to a higher level here in terms of the sort of geopolitical world of American healthcare. But yeah, I think it's going to be ultimately an interesting, I want to say it's a race, but to see who can organize these physicians and how those physicians can best, take advantage of these new payment models. And I think it opens a lot of doors. But as I say, ultimately, I think the balance of power in American healthcare is going to move away from hospitals and I think have already kind of moved away from insurance companies, but moved away from hospitals to other types of organizations, some which exist today, but some which will be newly formed in the future.
Yeah. And yeah, that got me excited about the future of healthcare. Like, that's awesome. Now I have to ask you as a sort of follow-up question of that is what really excites you most about the future of healthcare?
Sure. I think two things. One is that I think there's tremendous opportunities to learn from what's going on all around the world. I think that many countries are pursuing very interesting, innovative strategies, and to date, there's been very little learning that's been going on. And so I think there's going to be, and that's part of what we see. Part of our role is when we do projects in one part of the country, we love to be able to share those best practices in other parts of the world. And I think I think that's, to me, one of the things that gets exciting is that there's a lot of learning that hasn't happened to date that could really move the value discussion forward globally. The second thing is that this emergence of these new organizations that really embrace the not only value-based care and value-based payment, but also the user experience and how to improve it also gets me really excited. I mean, I'm excited about companies like Galileo, which recently had started with some venture capital. The venture capital funders got a 10-year horizon for return on that investment, almost unheard of in the VC world.
Yep.
But it's a virtual it's basically primary care with no walls for very complex, vulnerable people. So that means that it's all about home visiting, virtual care services. There is no bricks and mortar clinic in their model. And they're not going to cherry pick. They're really focused on Medicaid and Medicare, very complex, chronically ill, socially complex populations. So they have to figure out a whole lot of stuff before they get there. But I love the fact that people are trying stuff, right? They're not afraid of complex populations. They're not afraid of really challenging the status quo. And I think that ultimately is what we need here, is willingness to sort of say, you know what, incremental reform isn't what we need. We really need to break the mold. We need people who are fundamentally willing to take some risks and develop some things and put them out there in the field to test. And I believe that's exactly what we're seeing today.
That's awesome. And I'm glad to have someone like you at the forefront of that, Jason. And, where can the people, our listeners, find you and connect with you if they want to hear more of all this awesome stuff that's going on?
Sure. So HelgersonSolutions.com is our website, and encourage folks to come check it out. On our blog section, you'll find lots of different things we've done, pieces we've written, so blog pieces, some different things we've written, some videos that we've done, all right there. But it's a great way to stay connected to us and see the things we're doing, what we're thinking, and what we're seeing, not only here in the U.S., but around the world.
Yeah, well, Jason, again, thanks so much for coming on and adding a ton of value to the listeners today. We'll have to have you come on. I could have dug like 1,000 feet deep in pretty much everything you said, man. So I really appreciate you, brother.
No problem. Happy to do it.
Awesome. Thanks. Have a good one, brother.